All right, let's jump straight into high-yield Step 2 CK dermatology. Today, we're focusing entirely on decision logic and morphological pattern recognition. When you're sitting for the boards, recognizing these specific clinical patterns is exactly the cognitive framework you need to arrive at the correct diagnosis quickly. We're going to cover pigment disorders, acne variants, and the key distinctions between different types of eczema. Let's get to it. Section 1, Clinical Skin Finding Patterns. Okay, let's dive into this and run through these rapidly. If the vignette gives you irregular, hyperpigmented facial macules, you think melasma. Acute, painful sun exposure with erythema? That's a sunburn. Sharply demarcated, depigmented patches point directly to vitiligo. Scaly, sun-exposed plaques with scarring alopecia is your classic presentation for discoid lupus. When you see open or closed comedones, you're dealing with acne vulgaris. But if they describe monomorphic papules immediately following a medication exposure, like high-dose steroids, you've got to pivot to drug-induced acne. For intensely pruritic eczema, always look at the age distribution. Coin-shaped scaly plaques are nummular eczema, while deep hand and foot vesicles are dyshidrotic eczema. And finally, a well-demarcated rash mapping perfectly to a specific area of exposure is contact dermatitis. Section 2, Pigment Disorders and UV. Let's put two major pigment disorders head-to-head. On one side, we have melasma. This presents as irregular, hyperpigmented facial macules. It's incredibly common in women, particularly during pregnancy. Your management here is all about minimizing sun exposure and using broad-spectrum sunscreens that block both UVA and UVB. On the flip side, we have vitiligo. Now, unlike the hyperpigmentation of melasma, vitiligo gives you sharply demarcated, depigmented patches or macules. You'll usually see this on the face, hands, genitalia, acral skin, or extensor surfaces. The mechanism here is the autoimmune destruction of melanocytes. So if you biopsy a lesion, you're going to see an absolute absence of melanocytes, and a wood lamp will really highlight that complete lack of pigment. Crucially, you must screen these patients for associated systemic autoimmune conditions, specifically autoimmune thyroid disease, lupus, pernicious anemia, and Addison disease. And this brilliantly illustrates a classic vitiligo mimic, tinea versicolor, or pityriasis versicolor. It's caused by the Malassezia globosa skin flora, which really thrives in hot, humid weather. It can present with hypopigmented, hyperpigmented, or even mildly erythematous lesions. But the key clinical distinction from vitiligo is that tinea versicolor causes only partial pigment change, and you'll often notice a fine scale. If you do a potassium hydroxide, or KOH prep on those skin scrapings, you'll see that classic spaghetti and meatballs pattern of hyphae and yeast cells. For ultraviolet light exposure, preventative counseling is something you're tested on. Patients need to avoid peak sun and wear protective clothing. A broad-spectrum sunscreen with an SPF around 30 or greater has to be applied 15 to 30 minutes before sun exposure. Once they're out in the UV light, that SPF needs reapplication every 2 hours, and definitely immediately after swimming. If prevention fails, sunburn symptoms typically start hours after exposure. A mild to moderate sunburn gives you erythema and tenderness, and you manage it supportively. Cool compresses, calamine or aloe vera, and oral NSAIDs. Now, severe cases with blistering or systemic symptoms, like fever, vomiting, headache, or dehydration, might actually need hospitalization, IV fluids, systemic analgesia, and wound care. Generally speaking, though, sunburns will resolve completely by days 3 through 7. Section 3. Discoid lupus erythematosus. Discoid lupus has a very specific morphological presentation. You are looking for scaly, erythematous plaques strictly on sun-exposed areas of the head and neck. As these plaques evolve, they lead to atrophy, hypopigmentation or dyspigmentation, and significant scarring. If this rash extends into the hair follicles, it causes scarring alopecia. Now, while discoid lupus can happen entirely on its own as an isolated cutaneous issue, keep in mind that up to 30% of these patients will eventually develop systemic lupus erythematosus. Treatment here emphasizes strict sun protection and topical anti-inflammatory therapy. Section 4. Acne vulgaris and its variants. Think of acne management as a strict, stepwise ladder. At the base, we have comedonal acne, closed or open comedones, usually on the forehead, nose, and chin. The first-line step here is topical retinoids, or salicylic, azelaic, or glycolic acid. If it progresses to mild inflammatory acne, meaning you're seeing papules and pustules, you add benzoyl peroxide to that topical retinoid. For moderate inflammatory acne, you escalate again by adding topical antibiotics, like clindamycin. Now, if you encounter severe inflammatory or nodular cystic acne, which is characterized by large, merged nodules and scarring sinus tracts, you have to add oral antibiotics. Finally, for severe nodular acne that's just unresponsive to these measures, your definitive step is oral isotretinoin. Just remember, if you prescribe isotretinoin, strict pregnancy prevention and rigorous monitoring are absolute requirements. For women, especially those dealing with premenstrual flares or moderate to severe inflammatory acne concentrated on the lower face and neck, hormonal therapy is highly effective. Combined oral contraceptives work well because the estrogen component is anti-androgenic, heavily inhibiting sebum production. Another option is spironolactone, which blocks the androgen receptor directly, inhibiting androgen biosynthesis and signaling. But you have to be careful. Spironolactone is absolutely contraindicated in pregnancy because of the risk of feminizing a male fetus, so you must always factor that into your clinical decision-making. Moving to drug-induced acne, the classic triggers to look out for are glucocorticoids, androgens, immunomodulators, anticonvulsants, antipsychotics, and isoniazid. The primary exam-facing keywords here are uniform or monomorphic papules or pustules. The lesions will look like they're in the exact same stage of development, and crucially, you won't see comedones, cysts, or nodules. Also, the location and the patient's age of onset are usually atypical for standard acne, and it won't respond well to standard acne therapies. The only real management step here is stopping the offending medication whenever it's clinically possible. Section 5. Atopic dermatitis complications. Atopic dermatitis is driven by an underlying mutation in the filaggrin gene. This leads to a fundamental skin barrier dysfunction, and it's almost always coupled with a family history of atopy like asthma or allergic rhinitis. You really need to track the age-based distribution here. In infants, the pruritic erythematous patches and papules typically involve the face, the trunk, and the extensor surfaces. But as they grow into children and adults, that distribution shifts specifically to the flexural creases, often showing up as chronic lichenified plaques. The standard topical therapy escalation starts basic, with daily emollients and trigger avoidance, then steps up to topical corticosteroids for acute flares, and finally uses topical calcineurin inhibitors as steroid-sparing agents when needed. Because their skin barrier is chronically compromised, these patients are highly susceptible to infectious complications. You need to be able to instantly compare impetigo to eczema herpetiticum. Impetigo, which is caused by Staph aureus or Strep pyogenes, presents with papules and pustules covered in a classic honey-crested adherent coating. Eczema herpetiticum, on the other hand, is caused by herpes simplex type 1, and it's far more severe. It presents as a painful vesicular rash with characteristic punched-out erosions and hemorrhagic crusting. This is a vital distinction for the boards that requires immediate recognition. Section 6. Eczema variants and contact dermatitis. Contact dermatitis splits into two entirely different pathophysiologic pathways. Allergic contact dermatitis is a type 4 cell-mediated delayed hypersensitivity reaction. Think poison ivy, oak, sumac, nickel, latex, rubber, leather dyes, or topical medications. It presents with well-demarcated erythema, papules, and vesicles exactly where the allergen contacted the skin. Irritant contact dermatitis, however, is not immune-mediated at all. It is a direct physical or chemical injury to the epidermal barrier from substances like harsh soaps, detergents, acids, alkalis, or honestly just frequent hand washing. It frequently presents with dry, fissured skin rather than vesicles. Now, what's really interesting about this slide is how perfectly it maps out the mechanics of irritant contact dermatitis. This is irritant diaper dermatitis. Because the injury is caused by direct, prolonged chemical and physical contact, in this case, skin breakdown from exposure to stool and urine, the erythematous papules and plaques are strictly confined to the convex, exposed areas of the skin. Notice the distinct, sharp sparing of the skin folds. The irritant just physically can't reach deep into those creases. That specific detail is exactly how you differentiate it from a Candida superinfection on test day. We'll wrap up by contrasting two specific eczema variants. Nummular eczema presents as distinct, coin-shaped, intensely pruritic, scaly plaques strictly on the extremities, and it's heavily associated with chronically dry skin. Contrast that clinical picture directly with dyshidrotic eczema, which presents as recurrent, deep, severely pruritic vesicles or bullae located exclusively on the palms of the hands and the soles of the feet. Recognize the morphology, know the distribution, and you'll nail the diagnosis.